Assalamu alaikum wa rahmatullahi wa barakatuh. This lecture will be about the upper urinary tract. We will talk about the kidneys and the ureter. So, in this lecture, we will describe the functional anatomy of the kidneys and ureters and the relation of the kidneys and ureters to the abdominal organs. And also, we will cover the blood supply and the lymphatic drainage and the innervation of these organs, I mean the kidneys and the ureters. And also, we will describe the basis for radiating or referred pain arising from the kidneys and ureters. We will talk also about the suprarenal glands and their functional anatomy. We will describe the abdominal aorta and the inferior vena cava, their origin, their course, and their major branches. So, about the kidneys and the ureters, we will be talking about um, in terms of the kidney, we'll be talking about the morphology of the kidney, the coverings, the relations of the kidneys to the other organs in the abdomen. We will talk about the nephron, which is the functional unit of the kidneys. We will talk also about the blood supply, lymphatic drainage, and the nerve supply. And we will also have some comments on the clinical anatomy and the radiographic anatomy of the kidneys. Once we finish from the kidney, we will move to talk about the ureters. We will know the parts of the ureters, the course and relations of the ureter as it descends from the kidney to the bladder. We will talk about the blood supply, the lymphatic drainage, and the nerve supply of the ureters. And also, we will discuss some clinical anatomy and radiographic anatomy related to the ureters. We will start with the location of the kidney, and the kidneys are located retroperitoneally on the posterior abdominal wall. And we have two kidneys. Each one is on the side, in each side of the vertebral column, and they extend from the last thoracic vertebra T12 to the third lumbar vertebra. And in this position, the kidneys are partially protected by ribs number 11 and ribs number 12. And if we look into the size of the kidney, so each kidney is about 10 centimeter long, 5 centimeter wide, and the thickness is about 2.5 centimeter. And if we look into the right kidney and the left kidney, we will find that the right kidney lies below the liver and the left kidney lies below the spleen. And if you compare the position, we will find that the right kidney is slightly lower than the left, and that is because of the presence of the liver superior to the right kidney. Since the liver will occupy considerable space on the right side superior to the right kidney, we will find that the right kidney is lower than the left kidney. And each kidney is surrounded by fatty capsule and sheeted in a connective tissue sac. And these coverings are very important, and we will discuss this in the coming slides. So if we look into the kidney, the external feature of the kidney, we will find that each kidney has two poles, the upper one and the lower one. And it has two surfaces, the anterior surface and the posterior surface. And it has two borders, the lateral border and the medial border. And at the medial border side, we find this place, and we call it the hilum of the kidney. If we look into the layers that cover the kidney, if we start from the inside to outside, we have the first layer covering the kidney is the capsule, and this is the deepest layer, and it is the fibrous capsule. After the renal capsule, it comes the perirenal fat, and this fat is covering the capsule. The third layer is the renal fascia, and the renal fascia is a condensed membranous layer, and this layer continues medially, and it also encloses the renal vessels, and also it extends inferomedially to uh, extend as the periureteric fascia. And if we look into this fascia, we will find that this fascia covers the kidneys and the suprarenal glands. Superficial or outer to this layer is the pararenal fat, and this is a retroperitoneal fat located outside the renal fascia, and this part is most obvious posterior to the kidney. So if we start from inside to outside, we have the renal capsule, and then we have the perirenal fat, then we have the renal fascia, and then we have the pararenal fat. All these layers are responsible to support the kidneys and hold them in their position. As I have explained before that, we have two borders of the kidney. We have the lateral border and the medial border. So at the medial border of each kidney, there is a vertical cleft, and this is called the renal hilum. And it is approximately at the level of the first lumbar vertebra. And in this place, all the vessels and structures that serves the kidney, like the vessels, the nerves, the structure that drain the urine from the kidney, will enter and exit the kidney through the structure which is the renal hilum. One more thing I want you to know at this place is what is called the renal sinus. So once we have all these structures coming into the kidney and leaving the kidney, there will be spaces in between, and these spaces will be filled with the fat. So these fat-filled spaces that are surrounding structures at the hilum, we call them the renal sinus. If we look into the relation of the kidneys with other organs in the abdominal cavity, we will find that uh, the liver, the duodenum, the ascending colon, and part of the small intestine are located anterior to the right kidney. And it's worth to mention that the right kidney is separated from the liver by the hepatorenal recess. If we look into the left kidney, we will see that it is related to the stomach, to the pancreas, to the spleen, to the colon, the descending colon, and to the jejunum part of the small intestine. It's worth to mention that structures that are directly in contact with the kidney, like the duodenum, the colon, the pancreas, they are not separated from the kidney by any layer or anything. So they are directly related to the kidney. While there are some organs or structure separated from the kidney by the visceral layer of the peritoneum, which is marked as the blue areas here. If we look into the posterior side, the kidney is related to the diaphragm, the costodiaphragmatic recess of the pleura, and the 12th rib at the right side, and 11th and 12th rib at the left side. Most inferiorly, the posterior surface of the kidney are related to the psoas major muscle, the quadratus lumborum muscle. You can see the psoas muscle, the quadratus lumborum muscle, and the transversus abdominis muscles at both sides. And also posteriorly, the kidneys are related to three nerves. These are the subcostal nerve, the iliohypogastric nerve, and the ilioinguinal nerve. So posteriorly, it's related to three structures related to the chest, three muscles, and three nerves. It's very important to know all this relation because any injury to this organ can injure the kidney or the vice versa. I mean, if you are doing any surgery in the kidney, you have to be careful to with all the structure near the kidney because they can be injured during surgery. If we look into the internal features of the kidney, we will see that the kidney itself can be divided into two main regions, the cortex, the outer layer, and the inner layer, which is the medulla. And if we look into the medulla, it has several cone-shaped pyramids, and these are called the renal pyramid. The base of this pyramid facing the cortex, and the apex is facing the pelvis, and they are pointing toward the hilum of the kidney. And if we look into the structure here, we will find that there are some representation of the cortex in the medulla, and which are the area between these pyramids, and this is called the renal column. And renal columns are the portion of the cortex that extend between the renal pyramid. One more thing that I want you to know here is the renal lobe. And the renal lobe consists of the renal pyramid, the cortex area near it on top of this pyramid, and the adjacent renal column. So for each renal loop, we will take half of the renal column from each side. So you have the renal pyramid, the overlying cortex, and half of the adjacent renal column, and this is called the renal lobe. And the nephron is located in the cortex, and then the filtration of the blood and the process of urine production will happen here, and we will see that the nephron is located, some of the parts of the nephron are located in the cortex and some of them are located in the medulla. And then you have the collecting duct where the urine will be collected, and then this urine will move into the papillary duct in the renal pyramid, and then from the papillary duct it will be drained into the minor calyx. From minor calyx it will go to the major calyx, and then it will go to the renal pelvis, and from the renal pelvis it will go to the ureter, and the ureter will convey this urine to the urinary bladder. So some more areas to know in the kidney: the renal sinus. And the renal sinus is the spaces within the hilum, and this space is filled with fat, and it surrounds the structure at the hilum. So this is called the renal sinus. The renal pelvis is actually the, if we go from, we started from the minor calyx, major calyx, and then the pelvis. If we go to the other direction, if we start from the renal pelvis, the renal pelvis will be divided into two to three major calyces, and each one will be divided into three or more, or two or three minor calyces. And each minor calyx is intended by the apex of the renal pyramid, and this place is called the renal papilla. The nephron, which is the functional unit of the kidney, is located in the cortex and medulla. So you have some parts of the nephron located in the cortex, and some parts are located in the medulla. So if we look into the cortex, we will find that the renal corpuscle is located in the cortex, with the proximal convoluted tubules, with the distal convoluted tubules, with some collecting tubules, and the upper part of the collecting ducts. And if we look into the medulla, we will find that it contains the descending and ascending limbs of lobe of Henle. It contains the collecting tubules and the collecting ducts, and these collecting ducts will drain into the papillary duct, which will drain into the minor calyx. One thing I want you to concentrate on here is the medullary ray. So although the name is medullary ray, so it's related to the medulla, actually this area is located in the cortex, and this area is formed by the upper part of the collecting duct. So the major parts of the collecting ducts are located in the medulla. Only the upper part of the collecting ducts is located in the cortex, and this is called the medullary ray. So regarding the blood supply of the kidneys are supplied by renal arteries, which are arising from the aorta at the level of the intervertebral disc between the first and second lumbar vertebrae. And the right renal artery is longer than the left renal artery, and it passes posterior to the inferior vena cava. And typically each renal artery divides close to the hilum into 5 segmental arteries. So you have the renal artery, which will divide close to the hilum into several segmental arteries. One important thing about these segmental arteries is that they are end arteries. It means that they don't anastomose significantly with other segmental arteries. And this is very important because this makes the area supplied by each segmental artery as an independent unit. And this is very important because if you want to remove one diseased segment of the kidney surgically, this makes it easy to do so, since each segment is supplied by a segmental artery. So removal of this independent segment of the renal tissue will not affect the function of the rest of the kidney. So if we trace the renal artery, we will find that it will be divided into several segmental arteries, and each segmental artery will give off several branches. These branches will enter the parenchyma of the kidney, and they will pass in between the renal column. They will pass in the renal columns between the renal pyramids, and here they will be called the interlobar arteries because they are going between the lobes of the kidney. These interlobar arteries will move up till they reach the base of the pyramid. So at the basis of the renal pyramid, the interlobar artery will arch between the cortex and the medulla, and here they will be called the arcuate arteries. So you have the renal artery, segmental artery, interlobar artery, and then you have the arcuate artery. These arcuate arteries will radiate outward, and then they will enter now the renal cortex. Once they enter the renal cortex, they will give branches called the afferent arterioles. And these afferent arterioles will go to the nephron. So each nephron will receive one afferent arterioles. In the nephron, each afferent arterioles will divide into a ball-shaped capillary network, and this is called the glomerulus. After the filtration process happened, the glomerulus capillaries will reunite again to form what is called the efferent arterioles. And these efferent arterioles now will carry the blood out of the glomerulus. One more thing that I want you to concentrate on here is the glomerular capillaries. These capillaries are unique among other capillaries inside our body. Why? Because these capillaries are located between two arterioles. So we have the afferent arterioles branches into glomerular capillaries, and then these glomerular capillaries will reunite to form the efferent arterioles. So I have capillaries between two arterioles, but we used to have capillaries positioned between an arteriole and a venule, but here we have capillaries positioned between two arterioles. These efferent arterioles now will divide to form what is called the peritubular capillaries, and these capillaries will surround the tubular part of the nephron. Then these capillaries will unite to form the interlobular veins. These veins will unite together to form what is called the arcuate vein. The arcuate vein will form the interlobar vein, and the interlobar vein will unite to form the renal vein. And this renal vein will leave the kidney and then exit through the hilum and carry the venous blood to the inferior vena cava. So if we look into the left and right renal vein, we will see that the renal vein is longer than the left renal vein is longer than the right renal vein, and you will see that the left renal vein is receiving the left suprarenal vein and the left gonadal veins. If you look into the lymphatic drainage from the kidney, you will find that the lymphatic vessels are following the renal veins, and they drain into the lateral aortic lymph nodes that surround the renal arteries. In terms of the nerve supply, the nerves to the kidney arise from the renal plexus, and this consists of sympathetic and parasympathetic fibers. The visceral afferent fiber that travel through or that convey the pain from the kidney, they travel along the sympathetic pathway. So they travel along the renal plexus and they enter the spinal cord at the level of the 10th, 11th, and 12th thoracic nerves. The renal pain is the pain resulting from the stretching of the capsule of the kidney, or it may result from the spasm of the smooth muscles of the renal pelvis. And this pain varies from being a dull ache pain to very severe pain, and it is referred to the distribution of the subcostal nerve. So the patient with renal pain will experience this pain in the flank and in the anterior abdominal wall. Some points about clinical anatomy of the kidney. If the kidney is get traumatized, or if we have kidney trauma from posterior aspect, there is most likely that injury to the ribs and pleura will happen. And also the vice versa, if we have injury to the 11th and 12th vertebra, we have to make sure that the kidney is not affected, because most likely the kidney will be affected if there is fracture on the 11th and 12th rib. There is a space or an angle between the 12th rib and the erector spinae muscles at the back, and this area is called the renal angle, and this is the best place to look for the renal tenderness. As I mentioned earlier, that the renal capsule, the perirenal fat, renal fascia, and pararenal fat are very important to keep the kidney in its place. If loss of the perirenal fat happen, this can lead to excessive mobility of the kidney, and this affect the kidney, the blood supply to the kidney. We will not go into detail about this, but to make sure that you know that a loss of the perirenal fat is affecting the mobility of the kidney in the abdominal cavity. Renal carcinoma, which is cancer in the kidney. One important thing that I want you to know, that the renal veins here play a major role in the spread of the renal carcinoma to other sites other than the kidney itself. The other thing that I want you to know here is the renal hypertension, and this is the high blood pressure resulted from the narrowing of the renal arteries. So the main cause of renal hypertension is the narrowing of the renal arteries, and this is the most common cause of secondary hypertension. The main items or strategies for treatment of such hypertension is to start with medication, but in most of the cases you need to reconstruct the renal arteries and overcome the narrowing of the renal arteries. So from this section, I want you to know that the renal hypertension is the most common type of secondary hypertension, and it happens because of the narrowing of the renal arteries, and surgical correction of this narrowing is one of the options for the treatment. We move on to talk about the renal calculi, stones in the kidney. So these stones can occupy the renal pelvis, and if they extend to the major and minor calyces, they will look like a horn of a stag, and that's why it is called the staghorn stone of the kidney. And patient with renal calculi will present to you with recurrent infection, fever, blood in the urine, and flank pain. The other clinical aspect that I want you to know about the kidney is some congenital anomalies about the kidney. First of all, I want you to know that kidneys are close together in the embryonic pelvis. So in the embryo, the kidneys are located in the pelvis and they are close to each other. What happens sometimes is that the inferior poles of the kidneys fuse together and they form a U-shaped kidney, or what is called the horseshoe kidney. And what happened during development is that the kidneys are in the pelvis and then they will ascend up till they reach the position that we know now. So what happened during the ascending of these fused kidney is that they will ascend and then the root of the inferior mesenteric artery will prevent the normal relocation of the kidneys. So in most of the cases, you will find that these U-shaped kidney or the horseshoe kidney lie at the level of the L3, L4, and L5. Associated with this abnormality is that sometimes this can cause obstruction of the ureter and some abnormalities at the pelvis of the kidneys. Here you can see the fusion of the inferior poles of the kidneys and how they look in the radiograph. One more abnormality is the presence of what is called the pelvic kidney, and that is happening because sometimes the embryonic kidney in one side or on both sides fail to enter the abdomen and they will stay inside the pelvis, so they will lie anterior to the sacrum. Although this is not really very common, but awareness of possibility of having ectopic pelvic kidney is very important because after birth, if the physician find the mass like this in the pelvis, he should be aware that it can be ectopic pelvic kidney and should not mistaken that with a tumor in the pelvis or something like that. During the ascending of the kidneys from the pelvis up to their final site, these embryonic kidney will be receiving blood supply and venous drainage from the superior vessels. And what happened actually when the kidney is ascending up, these inferior vessels will degenerate and the superior vessels will take over. So sometimes what happened, the inferior vessels will fail to degenerate and this will result in what is called accessory renal arteries. And the common type of accessory renal arteries are the polar arteries, and they are called polar because they are related to the poles of the kidney. And these accessory arteries, they vary in terms of location and in terms of numbers. And sometimes they might associate with the obstruction of the ureter, especially with the inferior renal artery. Now we will move on to talk about the ureter. And the ureter is the muscular duct that is about 25 centimeter long and it's designed to carry the urine from the kidneys to the urinary bladder. So the ureter is lined by epithelium, which is called the transitional epithelium. This type of epithelium is very important because it allows the distension and expansion of the tube. And if we examine the ureter radiographically, we will find that there are three constrictions along the course of the ureter. The first one is at the junction of the ureter and the renal pelvis. The second one is where the ureters cross the brim of the pelvic inlet. And the third one is when they pass through the wall of the urinary bladder. These constrictions are potential site for obstruction by the ureteric stones. If we look into the course of the ureters run inferiorly from the renal pelvis at the hilum of the kidney, and they passing over the pelvic brim at the bifurcation of the common iliac arteries, and then they will run to the lateral wall of the pelvis to enter the urinary bladder. The abdominal part lies on the psoas muscle, and the psoas muscle separated from the transverse process of the lumbar vertebrae. And as I said, it will enter the pelvis by crossing the bifurcation of the common iliac arteries, and that is in front of the sacroiliac joint. The pelvic part, as I said, it will run on the lateral wall of the pelvis, and it will turn forward to enter the superolateral angle of the bladder. One thing I want you to know here, that although we don't have anatomical valve at the opening of each ureter into the urinary bladder, there is what is called a physiological valve, and this is very effective to prevent backflow of the urine. And this valve is mainly occurring because the ureter is moving or traveling a distance while it's going from the outer surface of the bladder to the inside. So it travels through the wall of the bladder. It didn't enter immediately. So when the bladder fills, the urine will press on the wall, and this pressure will compress on the oblique opening of the ureter, and then the ureter will be closed, so the backflow of urine will be prevented. If there is any problem with this physiological valve, then the backflow of urine will happen, and there is a possibility that microbes can travel from the ureter through the ureter from the urinary bladder, and this can infect the kidneys. If we look into the relation of the ureter to the organs inside the abdominal cavity, we will find that there are some differences between the right ureter and the left ureter. The right ureter is anteriorly is related to the duodenum, the terminal part of the ileum, the colic and ileocolic vessels, the gonadal vessels, and the root of the mesentery of the small intestine. While the left ureter is related to the sigmoid colon, the sigmoid mesocolon, the left gonadal vessels, the inferior mesenteric vein, Posteriorly, the psoas muscle will separate the right and left ureter from the lumbar transverse process. If we look into the final part of the ureter in the pelvis where it enters the bladder, we will find that the male ureter is crossed by the vas deferens, as you can see here. While in the female, the ureter is crossed by the uterine artery before it enters the bladder wall. Regarding the blood supply to the ureters, actually, the each ureter is supplied by multiple arteries along its course, and these branches come from the renal artery, from the gonadal artery, from the common iliac artery, and some from the internal iliac artery, especially through the superior vesical artery. And in the female, there are additional branches coming from the uterine arteries and the vaginal arteries. And actually, these branches approaching the ureters medially, and then they divide into ascending and descending branches, and they will form like anastomosis on the ureteric wall. The venous blood will drain into the veins that correspond to the arteries that I have mentioned earlier. If we look into the lymphatic drainage of the ureters, we will find that the lymph drains into the lateral aortic node, especially from the superior part of the ureter, and into the iliac nodes, and these are coming from the middle part and the inferior part of the ureters. When it comes to the nerve supply, the ureters are supplied through the renal, gonadal, and hypogastric plexuses. And the visceral afferent fibers, which are conveying the pain sensation, actually, they travel with the sympathetic nerve. And then they enter the spinal cord in the first and second segment. And, uh, and the referred pain from the ureter usually uh, referred to the ipsilateral lower quadrant of the anterior abdominal wall and to the groin as well. Intravenous urography is a procedure that is used to visualize the kidney and the ureter. It's also called the intravenous pyelography or excretory pyelography. And by this uh, pyelography, we can study the renal parenchyma, the pelvic calyces system, the ureter, and also the urinary bladder can be examined. Some notes on the clinical anatomy of the ureter. The injury to the ureter is very rare because it is located in a place where it is protected. And the other thing is that it is very small in size, so the injuries to the ureters are really very rare. And if we have stones in the ureter, there are three main sites where these stones can obstruct the ureter, and we have talked about them previously. The renal pelvis and the ureter, they, if there is a colic, there will be a spasm of the smooth muscle, or there is a distension of the pelvis or the ureter, then they will send the impulse through the afferent nerve into the spinal cord segment T11, T12, L1, and L2. Some congenital anomalies about the ureter: we can have bilateral double ureter, and this is caused because of the division of the ureteric pad at the embryological period, and the extent of this duplication of the ureters depends on the how complete is the embryonic division of the ureteric bud. Now we'll talk about the suprarenal gland, and these glands are located between the superior-medial aspects of the kidney and the diaphragm, and they are surrounded by connective tissue which contain the perinephric fat, and they also enclosed by the renal fascia. And the renal fascia is very important here because it will attach these glands to the crura of the diaphragm. Although the name suprarenal indicates that these glands are related to the kidney, the main major attachment of this gland is to the diaphragmatic crura. And there are some differences between the right suprarenal gland and the left suprarenal gland. The right suprarenal gland is more of pyramidal in shape, and it lies anterolateral to the right crest of the diaphragm, and it makes contact with the inferior vena cava anteromedially and the lever here anterolaterally, while the left suprarenal gland is crescentric in shape, and it lies behind the pancreas, and it's also behind the Lister sac, and it rests on the diaphragm posteriorly. If we look into the internal structure of the gland, we will find that the suprarenal gland has two parts, has the cortex and the medulla. In the cortex, it has three layers. It has the zona glomerulosa, zona fasciculata, and zona reticularis. And each layer is responsible to produce different hormones. Like the zona glomerulosa is responsible to produce mineralocorticoids. The zona fasciculata is responsible to produce glucocorticoids, and the zona reticularis is producing the six hormones. If we look into the inner medulla, is the place where the catecholamines are produced, which are the epinephrine and norepinephrine. And because of the endocrine function of the suprarenal gland, it received abundant blood supply, which is necessary for their endocrine function. So, if we look into the blood supply or the arteries that are coming or bringing blood to the suprarenal gland, it receives, so each gland receives branches from the inferior phrenic artery and from the aorta directly, and some from the renal arteries. So there are three main sources of arterial blood supply. And if we look into the venous drainage, in the right side, the gland is drained directly into the inferior vena cava, while in the left side the gland is drained into the left renal vein. In terms of lymphatic drainage, all the lymph vessels go to the lateral aortic nodes. This gland is receiving preganglionic sympathetic fibers, and most of these nerve fibers going into the medulla of the gland. Now we will talk briefly about the abdominal aorta and branches of the abdominal aorta. The abdominal aorta starts at the level of the thoracic vertebra number 12, where it enters, it pierces the diaphragm, and it ends at the level of the fourth lumbar vertebra, where it divides into the right and left common iliac arteries. So if we look into the abdominal uh, aorta, it has branches that goes to the abdominal cavity and diaphragm, and branches that are going to organs inside the abdominal cavity. So the branches that are going to the abdominal cavity and the diaphragm are paired branches. So you have left and right of them. So we have left inferior phrenic arteries and right inferior phrenic artery. We have left lumbar arteries and we have right lumbar arteries. And if we're going to the branches that are going to the organs in the abdominal cavity, we will find that we have some of them are paired and some of them are unpaired. So some of them you have right and left, and some of them you have only one branch. So the renal arteries, we have right and left. The gonadal arteries, which are the testicular arteries or the ovarian arteries, you have right and left. While the branches that are going to the gastrointestinal tract are unpaired. So you have one celiac trunk, one superior mesenteric artery, and one inferior mesenteric arteries. Inferior vena cava is formed by veins that are following the arteries, and you can see that the external iliac vein unite with the internal iliac vein to form the common iliac, and these two common iliac will unite together to form the inferior vena cava, and then the inferior vena cava will receive veins from the lumbar veins, and then you have the renal veins, and you have some gonadal veins coming here. You have the suprarenal glands, you have the inferior phrenic. So the veins will follow the arteries. But here I want you to appreciate the differences between the right renal vein and the left renal vein. In the right renal vein, you have the vein directly joining the inferior vena cava, while in the left side it receives some branches from the suprarenal vein, some branches from the gonadal vein, and they are receiving also some branches which are the ureteric branches. And you can see that the left renal vein is longer than the right renal vein.